Hi, everybody. Thanks for joining the VTC Wilderness Medicine Journal Club series. This is the April 2025 session covering uh, non-freezing cold injuries and warm water immersion injuries. I know the advertisement for just saying immersion injuries might have been kind of confusing, but it's hard to put that whole title into a tiny little space. So, as I mentioned just a minute ago, our speaker who's supposed to be presenting the guidelines is not able to attend due to an illness. I can give a very brief uh, rundown of the definitions, but despite reading all the articles as of the last 5 minutes, I don't want to just read it to you. It's going to be really boring. You're not going to gain anything from me just reading an article to you. So I strongly recommend it's in the article library in the Google Drive folder. Just go to the WMS guidelines that are linked there and just give it a read. It's really interesting, but me just reading it to you last minute is not really going to help you. Um, I'll read a couple definitions and then we'll have Project take it away. So, has anybody heard of trench foot? Pretty well known topic, whether you've heard of it just in passing, whether you've seen it in person or not. So, does anybody know where trench foot, the term came from? It's kind of in the name, but
World War I.
World War One, yes. So there were a ton of different names for it. An article I believe I put in the library in the Google Drive mentions it's really cool. It's like quotes and like a detailed understanding of how the US and the Brits during World War One kind of came up with it separately because each country has their own medical service for their troops. And there were a lot of differing thoughts to what caused trench foot, which now we know is essentially a type of non-freezing cold injury. Some people attribute it just generically to like immersion foot, whether it's cold or warm, but generally it's more so a cold water immersion. Um, does anybody know what differentiates frostbite from non-freezing cold injury?
In frostbite, the tissue actually gets frozen.
Yeah. Yeah, that's literally the difference. So the other version is non-freezing cold injury in general is immersion or submersion in water. Frostbite in general is just like a cold air and wind. Immersion is what causes the non-freezing cold injury. The temperatures can be very similar, but it's doesn't actually freeze. So the actual definition by temperature is prolonged exposure of the extremities to cold, wet conditions with water temperatures less than 15 degrees Celsius or less than 59 degrees Fahrenheit. Um, if it's a non-water exposure or submersion, it's typically much colder air temperatures, but still not frozen. There's going to be some content covered about warm water immersion, but just to make things more clear for what the difference between non-freezing cold and warm water is, it's essentially just the temperature. So warm water immersion gets somewhat subcategorized to warm water immersion foot and tropical immersion foot. Tropical is more severe. So warm water immersion is, let me let somebody else into the waiting room. Okay. Warm water immersion foot is feet get white, wrinkled of the soles predominantly, and then tropical is more severe than that. So warm water, it's exposure to water temperatures between 59 and 90 degrees Fahrenheit for fewer than 3 days. It's typically also known as paddy field foot, and this got more so seen, at least from the Western world in like the Korean War and Vietnam War and things like that. And I suppose the Pacific theater of World War II. So the timeline for warm water immersion foot is typically 1 to 3 days. You basically elevate the feet and dry them off. It's pretty routine care. Tropical immersion foot is warmer water. It's 72 to 90 degree water for again more than 3 days, and you dry it, elevate it, but it can take up to 4 to 12 days, and they can get like more so prone to fungal infections because just breakdown of the skin. They do get bacterial infections, but specifically more fungal. Now, the actual details again, it's a full, I don't know, 10-page guideline, and not just reading it to you, not gonna, it's gonna be like a med school class. So let's not do that. So, Prajwal, since you're here and I don't see Danny in the group yet, are you okay taking it over for the first article?
Yeah, sure.
Cool.
I'll
I'm
share
gonna
my
mute
screen.
myself and I'm gonna try and drum up Danny. And share screen should be enabled if you need it.
Okay. One sec. All right, can you guys see this? Okay. All right, so the article, okay. Yeah, so talking about this article, non-freezing cold injuries among long-distance polar rowers. Um, so kind of going through the the template that was provided about how to discuss these articles. The purpose, wasn't made super clear in the article about why they were studying this, but it seems like part of it is because non-freezing cold injuries are a condition that's often underdiagnosed, but can cause lasting morbidity in people working in cold conditions. And it looks like they were trying to assess some of the environmental and individual risk factors for non-freezing cold injury. And they also described the clinical course for some of the patients that they identified in their study that had the non-freezing cold injury. A little bit about non-freezing cold injuries. So as we just discussed, it's synonymous with trench foot. And it was first described during World War I, but even during Napoleon times, like they had also described the same condition during that war. It's also known as immersion foot, sea foot, bridge foot, and really it's just exposure to non-freezing water, just moisture. Um, there's four stages to the condition. So the first stage is cold exposure. Followed that, you get post-exposure, and during that, it's characterized by the tissue feeling numb and heavy. And then after that, you have the hyperemic phase with bounding pulses. And then you get the post-hyperemic phase where the foot and the tissue will look normal, but you'll have persistent numbness and pain. There's other non-freezing cold injuries, non-freezing injuries that have been described, like the chilblains you might have heard about. So this is just an inflammatory condition causing discomfort. Cold urticaria, so you think about hives and like an allergic reaction, and cold exposure can also create that kind of skin condition. And the Raynaud's phenomenon you've probably heard about in patients with like autoimmune conditions where you'll have like the vasospasm and once you get exposed to cold. So but all of these are separate from non-freezing cold injuries, and the main difference is the exposure to the moisture. The other ones just require exposure to cold weather. So they looked specifically at this expedition called the Polar Row Expedition. Pretty interesting. It seems like it's an 8-day expedition. It broke up into 2 legs, and you have the rowers going all the way from Tromsø, Norway, all the way up to um, this area, Svargard, and really they start out with a total of 4 rowers, and then they have a break point where they spend about 30 hours in this area marked on the map, and at that point they switch out 3 of the rowers and replace them with four new rowers. So that's kind of how it goes. And then the rowers, it's notable because they get a lot of exposure to cold water. You can imagine the water spilling into the boat, and just the overall cold temperatures. They take turns rowing 90 minutes at a time. So each rower will row for 90 minutes and then take a break. And these look like pretty small rooms, but I guess they actually look kind of spacious if you look up other photos online, and they kind of take breaks in there where they can exchange their clothes and eat some food, and things like that. So that's it. So the researchers for this article were from the UK at these universities, and then they didn't specify like a specific hypothesis, but just based on their study, you can kind of think that this is what they were thinking about, like risk factors for people who are going to develop non-freezing cold injuries, so including Afro-Caribbean ethnicity, and they thought that dehydration would be some potential risk factors. So this is kind of what I described. Oh, it was actually 5 rowers in leg 1, and then 3 get replaced. It's 4 new rowers. So a total of 6 rowers for the second leg. And most of their data analysis and risk factor analysis came from the second leg, those 6 rowers in the second leg. And the total length of the expedition was 1,251 nautical miles. So a little more about the conditions that they were experiencing. So listed here, the first part of the trek, I guess, was 8 days, and the second part was 13 days. And they're exposed to non-freezing temperatures, 6 to 9 degrees Celsius. And the second leg is what they describe as having more exposure to that really cold water. There were larger waves that would be breaking into the boat. So that's why I guess they picked the second leg of rowers to conduct their analysis on. So how did they analyze the risk factors? They made anthropological measures on the second leg rowers. So they measured their height and their body weight, and they used a bioelectric impedance analysis machine to analyze their body composition, like fat composition and fat percentage, and a lean body mass percentage. And then they performed sample t-tests to compare the group of rowers who developed the non-freezing cold injury and compare them against the group that didn't. So these were their observations. They found that the individuals that developed the non-freezing cold injury tended to be taller, heavier, have a higher BMI, higher fat percentage, higher lean mass. So it just seems like the larger people. But also interesting, it's people who lost more weight during the expedition and those who ate less food during the expedition. So those are some of the commonalities between the people who developed the non-freezing cold injury. But I guess most interesting was the data here. And I just want to draw out this point where none of these factors were meeting statistical significance. And as you can imagine, it's because of the low sample size. They only have a total of 6 people. So 3 of them developed the non-freezing cold injury, and then 3 of them didn't. And then they gave a little bit more information about the actual symptoms that were experienced by the people who developed the non-freezing cold injury. And it was kind of similar to what I explained in the first slide with the numbness in the first few hours, followed by the hyperemic stage. And then what was more interesting was some of the lasting symptoms that they had, like the chronic pain symptoms. The patients 1 and 2 were initially treated with just Tylenol and codeine, but they didn't have any improvement in those symptoms until they were started on amitriptyline. And then it seems like once they were started on regimen with including that, their symptoms resolved. But patient 2 just still has some cold sensitivity after that 16-month mark. And then patient 3, he actually had some improvement with just Tylenol and codeine. So most of his pain symptoms resolved, but he continued to have some numbness on the second toe of his left foot. Just going into some of the strengths, I think this paper is a nice, interesting starting point to start looking into non-freezing cold injuries. It kind of identifies some potential risk factors and then what some of the clinical course for these patients might look like. But obviously, it needs some more work with having a larger sample size and more rigorous statistical analysis. Limitations, like mentioned, and then they also didn't. I think it would have been nice to just clarify the duration of exposure that is typically associated with non-freezing cold injuries. I couldn't find many papers that described how long you actually need to be exposed to colder water to develop this. I think it would have been interesting if we could, somehow go back in time and maybe talk to some of the veterans that had been in these older wars where conditions weren't as good and they had more exposure to cold water and cold conditions, just to see like how many of them continue to experience like the neuropathic pain that you get from non-freezing cold injury. So this is something kind of like that. There was a paper that was published on these UK soldiers who fought in this war, and of those they did a survey on 3,000 members, and then 64% of them reported that they have a non-freezing cold injury. So I think this would be a nice next step for this group of researchers to maybe see people who have already had exposure to cold water for extended period of times, like how many of them continue to experience the numbness and symptoms from NFCA. So as mentioned, none of the risk factors that they mentioned reached statistical significance. I don't think any definitive conclusions can be drawn from it. But they did reference some other literature that also suggested that poor nutrition during these times could be linked to a higher incidence of non-freezing cold injury, which is interesting. I think for my practice, I would be mainly interested in like whenever I encounter a patient in the emergency department who, maybe in the summer months when it's no longer cold and they're still complaining of, chronic pain, especially in the hands or feet, I'll definitely think more about non-freezing cold injury. I'd probably be more like, before reading this article, I'd be more likely to just think about, diabetes or some other condition that's associated with neuropathic pain. But, given that I'm from St. Louis and we do have some colder winters and um, people who sometimes don't have like great access to warm conditions and like warm shelter during those winter months, we definitely see a lot of cold injury. So this is something I'll definitely think about more. So that's it.
Thanks. Great job. Very thorough and very organized. So thank you very much. Um, Looking at what was it, 6 people included in this report, as they didn't reach statistical significance, does anybody have some theories for why that subset did seem to have higher, not technically statistically significant, but higher risk? Why would why would weight loss being a larger size and things like that maybe correlate to higher risk in theories?
The metabolic, like there's little metabolic input, especially for someone that is bigger, even
Mhm.
though they're probably more fit. But once you're taxed, I mean, you're taxed at that point.
So yeah, I agree with your point. And there's also Justin mentioned, I'm not speaking in third person here. There's another Justin in the chat, I promise. Impaired microvasculature. So they're all relatively athletic people. I mean, I don't know too many just like Joe Schmoes who take this road trip across a sea. My thought is, so they're losing more weight, they're bigger. My personal thought was they're just suffering more. And if you're suffering, you're probably not taking as much time to take care of your feet. So my thought is generally they're probably not taking that time to just do good foot care. Is anyone in this group really into like whitewater kayaking or rafting and does like a lot of water activities? More of a land group? Okay. What type of
I mean, I
footwear do
used
you
to be.
wear? Pre-ACL. Um,
Yeah, back in the good old days, used to be.
so what type of footwear do you wear when you're like whitewater rafting?
Um, a lot of where I was, you could get away with like dry boots. So like, you got the wetsuits and you can just like throw the booties on, and then some people would wear water shoes over them. But
Mhm.
we had like one guy that would wear full on like lace up boots that were like specialized made for cold water. So
Interesting.
you could swim in them pretty okay, but I think it was more like rescue gear rather than, you know what I mean? Not really for.
I need to look into those boots. I don't think I've heard of those, but if you're wearing a dry suit, which like she's saying a wetsuit, but literally you're wearing like warm base layer with a waterproof outer shell, it's like what you see the cold Arctic scuba divers wearing, that kind of stuff. That, yeah, sure. If you can be 100% waterproof, you're fine. Let's say you're gonna get wet, you're preparing to be wet. Do you just wear tennis shoes or should you just wear tennis shoes and cotton socks? You should probably just wear
Mm.
like chakas, some type of like easily laced, not um bogged down, not like poorly drained footwear. Um, what do I wear? I wear Astrals. They have really grippy soles. Like you can just like hop on rocks that are wet and you're fine. And they're mesh, and at the front and the back and the sides, there's holes so all the water will seep out. Because if you keep your foot consistently wet for hours and hours, we're talking on these trips, we're talking days and days. I know people just came back from a 3-week Grand Canyon trip. So if you can't keep your feet healthy within those first couple of days, you're going to be miserable. So one of the articles in there was talking about a guy on one of these Grand Canyon trips. He was actually a guide. It was his first trip of the year. And then he got in pretty rough shape. He was like completely incapacitated within, I think it was day two or day three. He had shoes that were closed, had tiny amounts of drainage, and he was not really at night perfectly drying his shoes, and he wasn't drying his feet off and like putting an alternative pair of shoes on. So like by day two, he had something called Tolio. It's the name that the river people in Colorado gave for like warm water immersion eventually. Well, it's depending on the temperature, but it's basically immersion foot. So it looks like the picture that he showed in his slides, but specifically a little punched out pieces, like a sandpaper appearance. It's just this umbrella term for the complications they get there. And all he did was dry his feet. And I think he put some protective powder on them, and just, he was fine. Some people use a specific type of grease. But basically you got to really be careful with your feet. This is probably a younger crowd, but has anybody seen the movie Platoon about the Vietnam War?
Yes, fantastic.
Okay. Okay. I was just like, man, if I'm the only one. So there's one scene in it where one of the guys is basically self-inflicts warm water immersion. Oh, good, 2 people. Because he takes bug spray and basically, yeah, palm gradient boot, pretty similar. Cool. He just gets his feet sopping wet, knowing that if you get something like that, you're out of the fight for at least a short amount of time. So there's just an example in a movie I could randomly think of about that. So this guide, when he was on his trip, within a day or two of him just drying and like protecting his feet, he was back in action. He was able to finish the trip. So the good news is, if you can get to this in time and properly take care of your feet and dry your feet between episodes of being wet, you'll get better quick. But you'll be like 2 days incapacitated. I don't know about you, but if I'm on a raft with somebody and I got 4 people on my raft and one's not paddling, I'm gonna be a little grumpy at that person. So like if you're out of commission, it doesn't just affect you. So he was talking more about non-freezing cold injuries. Luckily, these people were relatively unscathed. One article that was supposed to be presented tonight, and the reason I'm babbling so much is because our second presenter's wife just had emergency surgery today. So one illness and one surgery took us down to, luckily, we have one great presenter and then me babbling. But the article was clinically about a patient with what looks like frostbite when you look at the pictures. But with his angiogram and his clinical history, he never actually had a freezing episode. Turns out he was a homeless person kind of hiding in a culvert with his feet wet, and the temperatures were above freezing, but like below 55-ish or so. So it classically meets non-freezing cold injury. However, he developed horrific paresthesias and like chronic pain to the like second and third phalanges of almost every toe. And they actually ended up doing iloprost. Does anybody know what iloprost is? I see a couple people nodding.
Yeah, they use it in frostbite now.
Right. So this article, they actually used it for, PGE. So they used it for a non-freezing cold injury. And as far as I know, and at least the articles mentioned in their story, it was the first time anybody had ever used iloprost as a non-frostbite treatment for a non-freezing cold injury. And their thought was, his symptoms might be non-freeze, more severe, but technically still non-freezing injury. But we're going to do iloprost. Problem is, I think they got it to him on like, he had already had NCFI for like 3 days. And a lot of the protocols for frostbite, their goal is to get you the iloprost within 24 hours of injury. He was already like 3 days in, but they're like, well, there's nothing else we can do. They maybe provided some benefit. They gave him weeks, I think, if not 1 to 2 months, as you should do with your frostbite patients, to let the tissue demarcate, so you know exactly where the problem is and where to amputate. He elected to have the amputation done because of the horrible symptoms, and they might keep calling it NCFI, and it technically is because there was no freezing, and the angiogram shows certain findings. I just want to pull up the picture. It is shockingly similar to the clinical appearance of frostbite. Part of me wishes they would just call it frostbite, because I'm not sure if I can get the quality to pop up. It looks horrible on my screen at least. Is that just super blurry to everybody? Yeah, I think it's because they have like the blurred background. And I don't think I'm going to figure out how to fix that in time to show you. But basically, it's in the guide. Just think of frostbite and his toes are black. So you might be tricked. And honestly, if you treat it with iloprost and you treat it with like aspirin and or TPA, I don't think you'd be wrong. But consider the angiogram and just remember not to cut right away. You want to give it time to demarcate. What do you guys think about Gore-Tex in this context? For feet, for shoes.
Great if it keeps more moisture out than it keeps in, but under a lot of conditions, it keeps the moisture in.
Yeah. It's like a lot of things in, I'll specify this to wilderness medicine. A lot of things in medicine, there's a lot of opinions, and you can see people on both sides getting rather heated, I suppose. Yes, thank you, David. Those are the pictures I tried to show. They're in the chat. Sure looks like frostbite, but technically it's NCFI. I have some shoes that are Gore-Tex. I would probably recommend not buying, almost across the board, not buying shoes that are like ankle height or lower that are Gore-Tex, because water's going to get in and it's going to get trapped in. If you can get really high shoes and they're Gore-Tex, you might be better chances of water not getting in. But however, if you sweat a lot, then that water won't evaporate either. So you're going to then have sweaty, wet feet. One article recommendation for water was exactly what we talked about already. Really good drainage, if not like bare minimum, to avoid trauma. Or just letting somebody in the chat. There we go. Or you can get really high, completely waterproof, like rubber boots, and then like tuck your waterproof shell in those. So then you can have like multi layers of protection, or just a dry shoot like Tylen mentioned. So there's options. The main thing is just not letting water get trapped at all. And if it does, make sure you catch it, take a break if you can, bring a dry bag with another pair of shoes and another pair of socks. At night, if you're on a multi-day trip, put on dry socks. If you start getting toes like this, I would again avoid putting your feet up against the fire like they mentioned for hypothermia and frostbite, because you could get burnt because you have decreased sensation. Don't rub if it starts looking like this, because you'll slough skin and skill superficial tissue. Pad dry if you're worried about skin breakdown. Don't rub. And just elevation. Aspirin might be great. So what type of bacteria would you expect if somebody has a warm water immersion and they get some like just skin like sogginess? What do you think would be involved?
I'd probably be worried about Pseudomonas.
Yeah. Especially if you're wearing shoes that are like not just single use for this trip or your things you wear around. I'd worry about skin gram negatives too. In general, these are not infectious though, like just across the board. They're more just like environmental injury. The recommendations in the guidelines do say update tetanus, consider antibiotics if indicated, and basically just dry, pain control, and elevate. And again, it's more likely to be fungal, and then you can just treat with your typical topical or like fluconazole. So any questions? Again, I know this is like a shockingly brief session because 2 of our 3 presenters had medical emergencies, but I think you could gain more from reading these yourselves than just me belabor the point. But any thoughts or questions?
Going back to the Gore-Tex and footwear, is vapor socks back in then in some of these contexts? Because that used to be the old school train of thought where you would do like a oven bag and then your socks and then your breathable boot.
I would probably just do anything you can to increase drainage and breathability. And if there's any reason you're going to wear Gore-Tex or I would make it just really high, like not maybe not even mid ankle boots. Like here, I'll just take my shoes off. I'm wearing some Hey Dudes. Gore-Tex in this height, never. If you're going to wear some that come up like mid calf, I think that'd be reasonable to go do Gore-Tex. I specifically got some in that height that are Gore-Tex, but anything shorter than that for me are non-Gore-Tex. TMI, I guess, but my feet get real sweaty and I don't want to have just like sweaty feet all day. I want them to dry out. So then I guess it's specifically with socks, I would wear some not cotton. They just never dry. They stay soggy forever. Wool, like a nice wool sock would be good. Thin, breathable. But yeah, just avoid sogginess. And just again, talk to people who have done it before. So you in that area before. So one point I wanted to mention here, and I'm going to share it in an email. Somehow my scheduler's messed up my month of May, and I'm currently working during the May session. So I think the easiest solution is to just move the session to the following day. So currently it's booked same time, 7 p.m. It's booked for, I believe, May 14th. I'm just going to switch it to the 15th and change nothing else. Same content, same Zoom link. It's just going to be a different day. So it's going to be the 15th at 7 p.m. Excuse me. And we're going to talk about eye injuries, which I've actually seen in the outdoors, and it's less fun than you do. I've actually had in the outdoors, and it's less fun than you'd think. Any questions about the topic? I think we covered what we could with what we had. So if one of the concerns I'm sure you have, and then I'll let you go, is technically for FOM credit, the WMS requires an hour of participation. There's literally, and I'm not going to talk for 23 minutes, so I'm just going to say everybody that's stayed till now just gets the full credit. So don't worry about that. So thanks everybody for joining. I'm gonna end recording. Otherwise, I will see you next month. We can chat after off the recording, but see you next month.
Thank you.